Welcome to episode 3 of the IT Refcast. I'm excited to have a dear friend on today for the podcast, and we're going to talk about some of the new administration projects and changes, and what providers should be on the lookout for as things are changing every single day. In addition, we have some other fun topics coming up in future, along with a live podcast from Naham that we'll be recording in April. So I'm excited for that one. Well, let's jump into today's hot topic. My guest today is an award-winning bestseller author of Joy's Notes, Balancing Trauma and Triumphs, one of the Modern Healthcare's 2021 top innovators, Black Leadership Worldwide, top 100 Black women in 2024 is a huge revenue cycle expert around innovation, just knowledge in general. I tend to have to lean on her quite a bit. The CEO of her own firm. Welcome, Neo.
Hi. Hello, everyone. Such a pleasure to be here.
I'm so excited to have you. Well, let's jump in. I figured we could talk about like staffing, we could talk about all those fun topics we've covered before, but I wanted to know a little bit more about what drove you into being an author. I mean, you've been a co-author and now you've authored your own bestseller. So I thought for listeners, it's not every day a revenue cycle leader stems out of the woodworks to become a best-selling author. So I thought let's start there. Get the listeners knowing a little bit about you first.
One thing that I realized as I kept going to HFMA events, I kept going to all of our revenue cycle events, and I noticed that we started detaching ourselves from the actual patient experience. And I got into revenue cycle because at 8 years old, I had to explain to my mother um, that she had cancer. And I was the one that was the translator. And I went as an 8 year old, I became parental in caring for her through that process, just as that translator and being by her side for every visit and so on. And that led me to revenue cycle. I knew I was not a clinical person, but math was my thing and revenue cycle made sense. But what I noticed is we keep talking dollars and cents and forgetting the patient. And I wanted to bridge that chasm and write a book that not only talked about the experience of being a patient when I had my 3 cardiac arrests, stroke, and multiple life-changing surgeries, which made my journey to be a patient my whole life. Um, I also brought that into how do you turn that into resiliency, perseverance, and thriving? Um, and how revenue cycle has a point in it because it's really easy to be a patient that is illiterate to their finances or illiterate to the care process. So through the book, we talk about all those aspects and um, it's an opportunity for you to prepare for what life is going to be when you're caring for your parents, your children, yourself in the journey of healthcare and surviving.
Yeah, no, I picked up your book and I've been reading little excerpts from it and trying to prepare for today. And what really stemmed with me was how much transformational journey you've had from that patient to, applying that to your daily work. I've also noticed, you apply that when we're speaking at national events together or just in general. What of that has helped you with like your own professional development and bring that back to your frontline team on a daily basis? Because what listeners who don't know you should know is not only are you running your own consulting firm, but you also are a VP of revenue cycle at a health system, and you're looking at it from multi lenses every day. So how has that like helped shape how you engage your team differently in that aspect and get them to see it from that patient lens or from that other vantage point?
Well, it really has taught me several things. Some people say, oh, just be a servant leader and you're going to be okay. It's beyond being a servant leader. It's being a purposeful leader. And what that means is it's taught me to listen to my staff, listen to what they are trying to tell us that we have opportunities with, and also listen to what seat they should be on that bus. Just because I hired you for X, that doesn't mean you're the best at X, but you're really good at Y. So letting you become the best that you are when you in your job in your site and having the flexibility to move and learn, that is when I am letting the team grow. And when the team goes into a trust mode with me, because I am delivering and listening and being there for them and giving them the tools to be successful, then we flourish. And the fact of the matter is, start with your team. Your eyes have to be on your team and look at them as whole person. And you'll be surprised that you will be performance will go along with that and the goals will be met, you know. And when you fail, learn from the failure. You will fail. But the most important things, they know that I will fall on the sword for them because it's my responsibility at the end of the day to keep a watch on what the work that has to be done is getting done. So I fall on the sword and we recover together.
Yeah, I think that is the utmost importance, right? When they see you fail alongside them, it bonds you even more so to be successful. And also, that component of I've been struggling with this as I've been writing a document today and working on my transition document of really trying to emphasize where team members have a need for support still, um, but at the same time, they're at this component of their journey as me as their leader looking like, no, they really need to rise to the occasion on their own. Um, I've given them what I can, and now it's time for them to find that mix and develop on their own. How are you, what are some of those tools and resources that you're using to branch out, to stay up on that on your own, or look at things through a different lens and insight that maybe like some of our younger listeners or even maybe newly into revenue cycle and switch from finance would want to tap into and grasps?
I looked away because I was going to pull out a book. Um,
That's me too. I'm always looking underneath.
Although I'm looking at my whole array of books that I'm reading all at the same time. Um, but one book that comes to mind is Ikigaya. Ikigaya is a Japanese term that talks about bringing yourself to full purpose. And in the book, it is a leadership book, and it's teaching a leader that you must let your people fail. You must challenge them. You can't put them and coddle them to the point that they're never making a decision, that they are not venturing into the step. That doesn't mean that you ignore them while they're in that. What it means is you have created a stage that is a safety stage, that they are safe enough to fail and know they will not be judged, that they will have the opportunity to grow. When you create that stage and you give them that freedom, and what Ikigai does, it gives them the ability to trust themselves and to enter into, everybody wants to start their day doing the best. What it does, it actually says, what do I do well? And where do I need to work on? So now when you're starting your day doing your best, you know what your challenge is and where to focus. And if we all start that way, we can actually meet our goals because we're taking steps towards them.
Right.
Otherwise, we're living comfortable. We live in what we know and what we do best without ever challenging ourselves. So I work very hard on challenging my team, getting my team to do what's uncomfortable, but being comfortable in taking the risk.
Yeah, I think the risk component, right? I remember just a month ago, I was at Western Region with you, and I'm like, what am I going to do? I have these opportunities. Which is the bigger risk? Which is the bigger potential for failure? And honestly, like just even leveraging your peers to talk through that risk, even as a leader, like as leaders, as we guide our teams, they really need to remember, oh, I have a peer probably going through this at the same time. Let me talk through what that looks like, what that risk looks like. How can we better journey from that? All
And
right.
and
Well,
and the other thing is, my level of risk comfort is different than yours.
right.
So as you're having that conversation with your peer, um, a good partner, and that goes into the Michelangelo effect. And the Michelangelo effect is saying, um, I'm going to be that friend that supports you, but challenges you,
Yep.
but does it in a way that you are not running away from your potential.
Yeah, and I think I love that effect in the sense of it really does lend back to that natural component for as a friend or a colleague to say we should remember to remind you, make a pros and cons list. What's your risk factor list? Like what's the risk to you? What's the risk to your family? What's the risk to the patient or the organization? Whatever the topic may be that you're really having to guide. I just was using that Michelangelo effect actually with my HFMA mentor or mentee actually to say to her as she's like asking me to help her make a decision. I'm like, no, no, no. No, no, I'm not doing this. Like, let's walk you through. Here's your homework and live with that and own that and rely on that. And I think that is once you're comfortable being uncomfortable, whether that's silence or whether that's just uncomfortable in your own skin, then you really are able to break down the comfort of growing as a leader and growing as an individual that can append that to other elements. I mean, I already am in my head a little bit this coming Monday. For listeners, I'll be starting my new adventure that I posted out on LinkedIn, and I like I'm in my head a little bit right now, but it's that uncomfortableness of me knowing it's okay to be in that headspace because it's going to set me up for that drive to want to be successful in the long run and have that. So I think that's a huge message. And I always get that message every time I hear you speak, whether we're on a panel together or co-facilitating or I'm just in the audience watching. That is one thing that I always get from you is being uncomfortable and being okay to have those uncomfortable conversations. And it's just so enlightening as we look at, our industry, especially our next topic after the break of really how uncomfortable are we going to get with the potential changes on the horizon and how are we going to recover from that will be part of the conversation.
True. But remember, in uncomfortable, there is joy because we're going to start and we're going to do things we've never done before.
Yep.
And that's exciting. I mean, I know it's ugly what's coming up, but we're going to be doing some stuff that we're going to look back and said, why didn't we do this before?
Yep.
So there's some great potential that's coming up next.
Absolutely. Well, on that note, let's take a quick break and we'll be right back.
The No Surprises Act requires hospitals to provide a complete self-pay good faith estimate for all providers involved in a patient's procedure, even if the providers are not owned or managed by the health system. The challenge is how to efficiently request estimates from independent providers, how to hold everyone accountable for their contribution, and how to provide a complete good faith estimate within the 24 to 72 hour delivery requirement. At Collective Health, we believe the solution is an agnostic portal where providers collaborate and share estimates while having visibility and accountability to each other. The Hive GFE Exchange is the industry's only solution that brings together estimates from individual providers into one consolidated GFE. CMS may have delayed enforcement, but is your hospital prepared for a comprehensive GFE? Don't delay. Join the collective. For more information, go to goodfaithestimate.com.
Claim Capital is a team of ex-Epic staff focused on preventing denials. Instead of showing what was denied, which is the standard for other solutions available today, Claim Capital pinpoints why claims are denied. By training machine learning models on an organization's claim and remittance data, Claim Capital can identify the causes of denials and recommend changes in EHR build or workflows to prevent them from happening in the future. With a completely HIPAA-compliant infrastructure, no software implementations, and a zero-risk pricing structure, organizations can quickly and safely recover lost revenue.
All right, and we're back. All right, well, let's move into the what we normally would call a debate, but I don't think there's any debating between you and me on this topic here. So it's really about more of what we're seeing out there in the industry and kind of the hot topic. And I think, from my perspective, Neo, we see a lot of safety net hospitals, FQHCs, county or state funded hospitals that are kind of they're not at always the forefront. We always think of like critical access because it's critical access, right? You're in a small rural community type of deal. But these really safety net or community-based hospitals are not always turned to because we're looking at the big motherships of the Banners, the Mayos, the Scripps, the Kaisers, the out there, Providence, etc., across the nation. And really, I want to target the conversation, especially around, the Trump's administration proposal around Medicaid funding, grant funding. What do you see as those potential impacts? Because you are representing one of those, hospital systems right now of being that safety net and in that community space.
Safety net hospitals have, in the last few years, especially during the pandemic and post-pandemic, they kind of revitalized themselves to become huge when it came to research. So research funding, NIH research has surged for those hospitals and has become quite a significant funding source in the private sector and with NIH. So the funds that are coming from the private sector would stick. But the NIH ones, there's a list of 90 words that if the contract had one of those words, and I want to say that the words include woman, female, they include diverse. Now, here's the problem with diversity. It's not diversity of humans. It could also be diversity of application. So cochlear ear, different types. So it's diverse set. But they look at the word diverse and diversity, and they're closing down those research projects. So because the word just appears, one of those 90 words appears, those research projects are being closed down. The NIH had last weekend had a major conference in Florida, and it was almost first of all there were supporters, Trump supporters that went to that conference and spray painted all over the different sessions that had any one of those words, not understanding what they were doing because it had nothing to do with diversity, the way they saw diversity.
It's about the diversity of the product, the solution, the component of what we're trying to support our patients through their medical journeys.
There's going to be a firing of undisclosed number of people that are doing cancer care research and closing down those projects. And those are patients that will not have any fundings and the project won't continue. So we're putting lives in danger. So here you have the safety net hospital that is in cancer projects, diabetes, chronic, diseases, and all of a sudden their funding goes away. Not only are we impacting their community, but we're also impacting the budget. The other things, when we look at the tariffs, we have to remember the impact to the budget. Everybody lives on a budget, and the budget had assumptions for their drugs. Well, drugs, because of the tariffs, are going to allegedly be 10 to 15% more expensive. That wasn't in their budget. That means they can support less people because they can only buy so much, right? And if we look at the Medicaid, depending on where this hospital is, and safety net hospitals are usually in urban or rural areas, right? They're usually your small community hospitals that are within 100 miles of each other, supporting a population in the urban areas of over 1 million, and in the non-urban areas, maybe only 200,000 people, but 200,000 people that have no other hospital for 100 to 200 miles. They will be crushed.
Yeah,
because
and won't it be putting at risk to the, like, if I look at like safety net or urban hospitals, there are some that they classify as safety net because they're the only hospital that provides that service within the range. So it might be there's another hospital down the road, but they're not doing behavioral health, they're not doing women's services. So that makes it even more important to really
well,
understand your community of what is your offering to ensure that are you classified as safety net or not. I mean, I can remember working for a safety net hospital and I didn't realize it because we were part of a big system, but at the end of the day it was we were the only ones offering that service in that entire geographic range. So
I'm glad that you brought that up. So safety net has a lot to do with the services. Do they do tertiary care? Do they not? Are they doing trauma? Are they not? But it's also, there's safety net hospitals that are part of a large system. And God bless them, because the large system compensates their lack of margin by the other hospitals that are much more commercial based and in more affluent areas. So they will have a much higher potential of survival than the standalone safety net hospital, which we have more of than the ones that are in the system. So you look at San Francisco, you look at Colorado, you look at, across the country, Texas, New York, and so on. There are large numbers of safety net hospitals that are under 200 beds. And they are the ones that are in the struggle because they are the ones that are serving that Medicaid population, which is already healthcare illiterate and financially toxic, because they are scared to get care because they think that they don't have the money to pay for it, so they don't even show up. So when they show up, they're chronically ill or in a very bad situation that costs more to care for them. So we are in a struggle. And I will tell you that this is where community is going to make the difference. This is where these safety net hospitals are going to have to align with community services, such as community groups that do funding for the churches, that the churches are supporting the care of patients by giving some money. Connecticut is a great example. In Connecticut, a lot of the churches have a fund for their parishioners. And if they don't have the money to pay for their care, the church will fund their deductible, their copay, or fund their care. So we're going to have to get creative as a society to figure out how to help people that need care. The other thing that we have to remember is Medicaid takes care of our disabled. We're talking about young children that will not have the ability to get the necessary care. We're talking about disabled people, the dual eligible that will be hurt by this cut. And Medicare is going to, basically, that's where they're going to go first, dual eligibles. So we don't know where the money distribution is going to be, but what we do know is we're going to have to be really thoughtful and mindful of how we do our business. And these small hospitals do not have the resources to have an innovative mindset. Um, so my call to action for all the companies that do innovation and they do AI and they have wonderful AI services. My call to action is have a program for your safety net hospitals. The price is at a lower price. Let them have an opportunity to stay open because they could take their task oriented work and automate it. That they can also have the innovation of machine learning and understand how their denials are being sent to them and how to fix them and how to get them out the door fast. Give them a chance.
I
It's
think
a different model, but we need that help.
Well, and I think it being a different model, it's an easier model. If you think about it from an innovation perspective, I mean, I always looked at it when I was rolling out a major change, rolling it out first at my smaller hospital or my organization because that instance, because I could have a more controlled point. When we look at having a controlled atmosphere and environment in a design model, that really becomes that element. So if we were to lean on as innovators of having our safety net or our smaller critical access, smaller organizations being that beta site or even the alpha site for us. And part of that development, one, you're going to be able to touch a different subset of payers versus your top payers, the Blues, the Uniteds of the world, and be able to focus in on how does this innovation have direct impact to the staff to improve them and help facilitate their training of being innovative themselves versus it just being, hey, give me a solution or technology that I can't afford. And that's why I can't maintain keeping it over a period of time.
Absolutely. And the other thing is, the sales cycle is a shorter sales cycle. Um, the desire to take a risk is higher because they already, they have no other solution. So, and you will also be able to get into reimbursement models that are different. Population health is a big core of the work that's done in safety net hospitals. So when we're looking for the professional services side, there is more population health models that they engage in. Locally, trying to reach into the CMS, you can help them move into the CMS models that they've died to get into, but didn't know how to scrub their data to be able to engage. But you can help them with that. There is so much potential there. And everybody is chasing the Sutters. Everybody is chasing, the large health systems. It's what we all, Baylor, and we can go on and on and on with all the names. But reality is America's heart, where they're hurting the most, is in the 1,500 small community hospitals that need your help now because of this Medicare, Medicaid change that's going to happen. That's 40 to 60% of their AR. They need your help.
Yeah. I think back to our think tank session where we were talking with managed care contracting and finance, the second one of the day at Western Region, and it really came down. What was eye-opening is I remember that small, I think it was Wyoming chapter
Mhm.
was there, and they were sharing like our providers are so far apart, and we don't like the next nearest hospital is 200, 300 miles away, and yet they're talking about their payer mix with us, and it is so, you know, Medicaid driven for their community that they don't have those larger employers where it's that employment model. Wait, as we start to see that even change, do you think we're going to start to see a shift towards more private healthcare models or more, or are we going to get a greater resilience on charity care as it represents funding resources? Like, I think that's where I get concerned for these smaller organizations. What are some of your thoughts on that?
Most definitely, we will start seeing higher private care models. It's already starting. We're calling it concierge. I was on our way to Vegas when we were going to the Western region. I was sitting next to a woman on the plane that their well, they were dental, but they also did PTOT, their group, and there was a big construction show that was coming on.
Oh, I
Well,
remember that. Yeah.
yeah. Well, she was there because they provide private care to the construction groups. And it's for dental and it's for PT and OT. And basically, they're not going through their regular insurance. They've carved it out from their regular insurance to private care. So we're going to see some very different models than we have ever seen. It was really interesting. I mean, the way that they do it, they direct contract with the employers and they say, look, we can give you these services, exponentially cheaper than you going through your regular insurance company, and your people will be taken care of. We'll get your people back to work faster than those guys because that's all we do.
Yeah,
And
I think that's an interesting model, right? Like, I mean, it's no different than when we're trying to negotiate, bringing it back to some of the other listeners who might not understand where we're at, but it's no different than when your managed care contracting team is going and saying, hey, instead of us talking to large health plan X, we know by running the data in our EMR system like Epic that these 39 employees or 150 of our patient population are employed by this employer because they're going through this plan. Let's go to that employer and now have a conversation about these services, lab, routine physicals, PTOT, ST, workers' comp related items come to us directly versus running it through your insurance component so that you can have it at a private contracted rate versus fee schedule versus at a here's our global fee schedule and now we're going to get a percentage charge or we're going to get a higher percent DRG rate and make it more cost effective for them.
Duke tried this about 10 years ago, and they were somewhat successful, but not fully successful because the market wasn't ready. So this has been tried before, that direct to market contracts from the providers to the direct market. But now it is really the way to go. And it's a new option. So now we have to look at it from that perspective that providers are going to have to get innovative on how they work, not so much with the payer, but actually work with the companies in their area that are taking care of their people.
Mm-hmm.
Because they can give them a better mousetrap if it's a direct contract. Now, you talked about charity care. Yes, we are in a very world of hurt of what charity care is going to look like. Because as we're chipping away from Medicaid, Medicare, then it goes into, what is open for free market care and, quote unquote, Obamacare. And more, the payers are already disappearing from that market. And the ones that are still in, we as providers are making decisions to run away from them because they're not paying on time. They're not reliable. They're not following their contract. So in a way, the way that is going to implode is that payers will stop engaging.
Mm-hmm.
And so if we don't have payers engaging, and it's already happening in several states, then where are people going to get care from? They're going to get care from the public hospital. And the charity care, where now maybe it's at 20%, is going to go back to the world prior to Obamacare, where it was 40 to 45%.
I think we're already starting to see that, right? Like I'm starting to see patients when they're secret shopping, they are calling one time and saying, "Okay, here's what my insurance plan is." They're going out online and they're pulling what if they're self-pay so that they know what that percent would be. And then they're calling for their insurance component so it's not tied. And then they're saying, "Oh, it's cheaper for me to say I want to go self-pay than what it is for me to go through my own plan at this point, even with my
That's right.
deductible out there." So I do think we're already starting to see some of that shift, and especially with more and more states across the nation now setting higher charity care percentages for that, and us trying to be better stewards and better advocates for our patients of setting that pricey, like, if it's 400% of poverty level or charity level, we're setting it to 600 because we want to widen that range so we're serving more of our patient population. I don't know if that's going to continue to be sustainable where we're going to have to pull back to actually be
We have to
equal with
pull
what
back.
the regulation is.
We're
So,
going to have to pull back to 300. But the problem is the range of 3 to 6 is the sweet spot. That's where most patients are falling in.
yep.
But we won't be able to afford that. There's no way. If the funding decreases, if the reimbursement is less, then we can't foot the bill for the sweet spot. So you're gonna start seeing charity care policies in change, and they're gonna go back to that 300 percentile or below,
Hmm.
which is a major impact to those self-pay patients, which
Right.
are going to increase because there's a void of insurance for them to go into. And us, the ones that are insured, what we will be seeing is where we're now at 3,000 being, you remember when insurance, we were like 2,000, 1,500 was our max
Yeah.
threshold.
Yeah.
Now the
Uh,
norm is 25 to 3,000 as the good insurance. The average is 5,000.
yep.
So the average for a family is 5,000. That's going to increase to 6 to 7,500. We are going backwards in our care model. We're not going forward.
Yeah.
So we as providers have to sit down and start getting really strategic about how we're going to handle this. The direct to employer is the first thing we should be considering. We should be doing our analysis of where our patients come from and how we can help those employers not to have to pay more. Because remember, the reason that everything is more is because the insurance company is elevating the price to them. So it's a trickle down theory. So we're going to have to think about going direct to them. We're going to have to get and embrace the community and come up with models so that we can support the people that don't have insurance and the people that are disabled. Um, Together, we can make this happen. But we have to get strategic and do it now. We cannot keep waiting, um, thinking it's going to change. It's only going to, it's going to happen, guys. It's not going to stop.
Yeah, absolutely. I think it's also us being more innovative too to say, how do we get, how do we also as healthcare leaders start to facilitate the conversations going back to, research, for instance, where grant study X might be washing up because they can't get nationally funded, but how do we go more back to that root of what research was, where PI initiated and we're really driving it by a provider, and then we're either internally funding it ourselves somehow or we're partnering with another organization in that, so it's joint research efforts. Especially, I was listening to the news, like OHSU here in Oregon, for instance, they're really concerned, a huge research organization, right? How much of that is going to impact? And then how much does that impact our community, not just for providing better care, but if they don't have those studies, those people are coming back and they're going to not have, potentially not have employment. And what does that mean? And how do we not have those data scientists and actual scientists out there doing that level? So we're going to have to find new means as we look for funding sources, whether it is, your your grant department that's helping write a new grant, or maybe it's a private, when we get a private donation and we're taking part of those donation funds where went to go to the general fund, and strategically we're going to put it more towards our own independent research component so that we can keep that driving. But I think one of those research elements that we've not done a great job in is that training sector, where taking research funding or grant funding and putting it back towards training of our teams, beyond the health, just beyond the patient care. Like, they do a really good job on the patient care side of that, but like on the administrative components beyond just revenue cycle, it could be within finance, it could be within, environmental services. But I think that training aspect of a lot of our staff are part of that. I'm going to quote unquote go back to my old Providence days, poor and vulnerable population, because they are making just slightly above minimum wage within the roles that they're working. So they might be insured by us, but they also might have that dual insurance. And we need to look at how we better train them and give them that aspect and resources too from funding. Um, what do you think as we start to pivot? Where are we going to need to, with these new potential payment models, or direct to the consumer or the organ, the employer? How are we going to have to quickly adapt to train our teams differently?
The training is actually not only our teams, but also the patients. We have three buckets of training that we're talking about here. We have to train our providers. And a lot of our health systems are doing a really good job with that because they're using AI. One of the things that innovation is when you look at what other people are doing in other industries and you reimagine it for your industry. That's true innovation, and what we have found is that all other industries have taken AI, which is innately set up to train, and used it to train the providers to understand, how do I facilitate for that patient, this patient, and this profile, how they can get their medicine, how they can get their care. And we can provide them that training, but also provide them those cues within their EMR so that they can look at the person as a whole person and not just say, well, you're going to need you're going to need X surgery and you're going to need this. And the patient's like, I don't have the money for that. I don't have the money for the copay and the deductible for that surgery. But they can, by looking at the profile of the patient, they could say, hey, we just saw that their benefits by this group gives benefits for a patient that is in your situation so that you can get that surgery, so you could get that medicine. We have over 80,000 benefit programs that are outside of standard insurance that are available to support our patients. But 50% of them are dried up every year because nobody plugs in. So there is money out there for us to plug into. So that's an education to the provider. We also can have that education available to our patient access people and the front desk so that they know when they're checking that person out, how to help that person and give them the benefits that they need. So the education is really understanding machine learning and not do at the elbow support education that we do based on function. Now we have to create critical thinkers. And to do that, we have to use AI training to provide that mix. And that is a big change of how we do training. When we onboard a person, what do we normally do? They do all those courses that they have to do to say that, they know where the fire extinguisher is and all that stuff. Great. Wonderful. So I did all those courses. I still don't know where the fire extinguisher is, but it doesn't matter. We check the box. And then we set them next to Alice, and Alice is going to tell them how to navigate Epic or Oracle, or whatever you're on. Doesn't matter. And they're going to get the certificate saying that they know how to navigate, and then they get their password. And I keep seeing them next to Alice, and Alice says, oh, this patient's coming in. He's a Blue Cross. This is what I do. Boom, 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 boom. And I mimic Alice. But what if Alice isn't doing the job fully? I just learned all Alice's bad habits. But imagine if I could have a true training program that takes that person with a simulation of what they're supposed to do. And as they are copying the simulation, same time, and we are giving them, hey, you made this mistake. This is the correction. And we guide them, and they have it available so that when they are doing their first few days with a patient, it's still prompting them to fix things. That's true training. When the training is about the individual, not a copy of an elbow person, that's when we're really training our people, and that's when we get the best performance.
Yeah. It's funny that you say that. I just was having that conversation last week at the end of the week with my team about like, okay, we did these core competency checks and you guys developed all this training. I've got an ask staff and I'm like, how's it going? They're like, well, we sat in a room. This person just basically dictated what we needed to do. And I was like, nobody asked you how you learn. Nobody said, let me sit with you and you do it while I look over your shoulder and say, oh, you could do this instead, which would be less steps, or nope, this is how you need to do that. Nope. And you're right, there is AI out there. It's making sure that we leverage that and invest in that. And then we also keep that up. And I think that's people's biggest fear there is, at least from other episodes that we've talked through, is how do I maintain that as I'm constantly changing my workflow on a continual basis? And what does that upkeep look like?
Well, and I venture to say it is cheaper for you to maintain that than it is for you to keep doing what you're doing that's giving you worse results. And by the way, AI can maintain it for you because that's the machine learning aspect. As if you keep that training agent to be viewing your current workflow and all the changes that you're doing into the current workflow, the training agent will update the training workflow to match it.
You're leading right into my next podcast after yours is about AI agents. So everybody, you should check it out so you know what she's meaning by agent.
There's several different agents, and the beauty of agents, just to give everybody something to like salivate about AI agents, you can create an agent at different personas. So you could have your agent that is your agent to help you with contracting, your agent to help you with clinical care. In fact, that's what we're seeing right now in the clinical care space with surgeries, that they have an agent that's overlooking the doctor while the doctor is doing the surgery and saying, oh, you left the sponge. A terrible example. But, it's telling them something that they may have missed or have a nuance of maybe not being aware of. So you could have an agent that is of any part of a process or a function. And the agent works with the person because you're going to have the human, the human in play to say, yes, I agree or don't agree. But the agent is going to queue and it's going to also create the task, leaving the person to actually more be the auditor and not even the auditor, but the final decision maker. And what it does is you could say, I have this report and I need to find every single cardiac arrest that happened in 2016 to 2025. And I want it to be female and I want it to be related to gut issues and all this, and have all this criteria. And the agent will give you the output you want because you're going to have a conversation with the agent as opposed to running 1,700 reports.
I think
So that's why agents are so important.
Yeah, and I think what people have to realize is that means we change our training to our teams because they now become these knowledge experts who are going to take care of the elements of the work the agent hasn't learned yet. And as the agent then learns that component, then we're raising our team to the next step and that next caliber. So it's really important that we as leaders really support our teams through being prepared to be a constant learner and and constantly receive education, and that we start to hire towards that for people who want that growth versus I want to come in and do a robotic process of what an agent would be the normal person to do.
Right. And even those people are necessary, by the way. And
Absolutely.
they're necessary because maybe those people are just doing the QA factor, right? There's going to be the ones that are going to be challenging the agent, and there's going to be the ones that are going to be accepting or changing or translating the work the agent is doing.
Yep.
So everybody has a role in it. But at the end of the day, that mundane task that the bolts and nuts that you don't want to do. I always say all the work you don't want to do, the agent will do. All the work that really thrills you and makes you happy, that's what you get to do. But the agent in training is phenomenal because the training is geared and curated for that person. We've never done that before, but the agent can create that.
Well, on that note, let's take a quick break and we'll be right back.
Are you ready to unlock the full potential of your medical coding team? Look no further than Adeo Technologies, the leading provider of medical coding productivity solutions. With Adeo's Gemini Solution Suite, medical coders are empowered and complemented with cutting-edge tools and technologies. The Gemini Coder platform, Gemini Autocode, and Gemini Coding Assist solutions work seamlessly together, creating efficiency and improving accuracy in medical coding. Say goodbye to tedious manual processes, cheat sheets, and memorization, and embrace the power of workflow improvements, artificial intelligence, and predictive coding. At Adeo, we believe in the collaboration between medical coders and artificial intelligence to create coding capacity that makes human coders more valuable to their healthcare organizations. Visit our website at www.adeo-tech.com. It's adeo-tech.com to learn why we love coders and how Adeo Technologies is transforming medical coding productivity one claim at a time.
All right, and we're back. All right, Neil, we're going to transition to what we call the Wilshire Lab. Usually that's when audience members will, or listeners and viewers on YouTube will submit questions to us. But I don't have any so far this season for us to start off with. So we're going to go with Daniel's and my traditional trend and pull him back into the podcast, even though he went off on his new journey. With this, what drove you to work in the healthcare industry? You alluded to it at the beginning about, being your mom, being an interpreter for your mom, but what was that spark that finally was like, yes, this is my journey?
Yeah, my mom's situation put me in the thought pattern that I was going to be a doctor. And I did really well. I actually got accepted to medical school. And then started taking classes and I realized I had to touch people to be a doctor. I know that's horrible, but I realized I was much more of a finance person. My mother is a mathematician and taught us math since we were little kids. I mean, we were 4 years old and we were doing long division. Same thing with my grandson and my son. I mean, she's an incredible teacher. And the love for math that was in my home made me want to go into finance, but I still needed to be in healthcare. So that kind of made me look at finance and healthcare. And I went in there first and then ended up in revenue cycle. When I joined Deloitte, I moved from strict finance into revenue cycle.
Okay, and then to wrap up our questions on you today, what's that one piece of advice as you look back, if you when you first started your career that you would give yourself today?
Don't limit yourself. I think I should have taken greater risk earlier on in my career. But the good news, it's never too late. So don't limit yourself, and remember, it's never too late. I keep saying the joy I have now that I have my own company and I'm able to be a supporter to many and do it, enjoy. I could have done it years ago, but the fact of the matter is I did it when I was ready. And I didn't limit myself. It took a long time to get to the point of, being willing to, go 100% for you. And I'm happy because I did.
Awesome. Well, everybody, to wrap us up, Neo, how do people get in contact with you if they have questions for you direct or want to grab a copy of your book or listen to your podcast even?
Wonderful. They can go to cairogroup.com or neocairo.com and also enjoy my podcast, which is Joy and Gratitude, which you could find on YouTube and wherever you love to get your podcast from. And please join me on LinkedIn. Be a follower. I do a daily blog about how to be a leader. And on Wednesdays, we do Leadership Wednesdays in healthcare.
Awesome. Well, that's it for us today. Look forward to AI next episode. And then I definitely will be having Neo back on. So thanks, Neo, for taking time out of your day. And that's it for us today. Bye-bye.
If you liked today's episode, continue to join Wilshire Wednesdays.
You can follow us on LinkedIn or Twitter at Evan_Wilshire. Daniel can be followed at Daniel_TWG. Wilshire Group at TWG Health. On Facebook at The Wilshire Group or on Instagram at Wilshire IT Revcast.
Remember, if you prefer to watch, come check us out at the Wilshire IT Revcast YouTube channel.
If you have an inquiry, want to share your thoughts, or get additional information on today's episode, email us at WilshirePodcast@thewilshiregroup.net.
The best way to support this podcast is to review, rate, and subscribe. See you next time.
Bye-bye.
The Wilshire IT Revcast is hosted, produced, and engineered by Evan Martin and Daniel Bianchini. It is executive produced by Gretchen Case, Hank Smither, and Spencer Thielman. The Wilshire Group. Experience you can trust, results you can count on.